the major trouble for any one of us, or the most dreaded complication, is ocular hypotony. We are often dealing with high pressures, but I think once we are stuck with ocular hypotony, the solutions are very minimal. So let's start the course, and I will first invite Dr. Uni to chair the session along with me, and Dr. Vishali. So I'll request Dr. Mohit Dogra, who is a senior vitreoretina consultant from PGI Chandigarh, to tell us about various risk factors for ocular hypotony, both early and late.
Thank you, ma'am. And thank you for the opportunity to be part of this instruction course. So I'll be talking on risk factors for ocular hypotony early and late. And prior to coming to those, just basically what is ocular hypotony? So there are two definitions. One is the statistical definition, which is great to put on paper. So it's IOP less than 6.5 millimeters, or as why it's statistical, because it's 3 standard deviation below normal. For all intents and purposes, that is meaningless. I think what's important is, yes, the cutoff of 6, but there's also a clinical definition of ocular hypotony, in which you can have pressures, any pressure which is like a single digit, but you have either corneal changes which can range from fine defolds to edema.
Mohit, can I disturb you for a minute? You're hardly audible because of this sound. Can we increase the volume of this mic?
थोड़ा इसका वॉल्यूम बढ़ा सकते हैं अगर पॉसिबल है
नहीं उधर अब उधर तो कम
मैं
नहीं कर
अपना बढ़ा लेता हूँ I'll try and yank it up a notch, ma'am. So the clinical definition is more important. So rather than actually looking at the 6.5 figure, if there is changes in the cornea or there is ocular hypotony, I have 2 representative images of the OCT in which you can have choroidal folds, you can have subretinal fluid, you can have a disc edema, there can be choroidal detachments in the periphery, all of which typically will signify hypotonic maculopathy. So even if the pressure is 9, but you have that, it's still hypotony, right? It's not 6.5 se kam hi hoga. And typically, as far as the mechanisms are concerned, there are 2 broad groups, either less aqueous, ya ban kam raha hai, ya nikal zyada raha hai. So less production or increased aqueous outflow. So if you want to look at, after that, the early causes of hypotony, so wound leak, which could be an overt or an occult globe rupture. This is in cases of trauma. You can have post-surgical leaks, particularly our glaucoma filtering surgeries or our shunt procedures. So you could have unsutured or poorly constructed corneal or scleral incisions, which could be cataract, SICS, sclerotomies for PPV, can have PK. So any surgery that you do, you can have acute or like immediate post-op micro wound leak, and which can cause early hypotony. You can have cyclodialysis cleft. Those clefts typically is the separation of the ciliary body from the spur, and it typically will be secondary to closed globe trauma. Could even be seemingly trivial trauma, or it can be sometimes due to surgery because of blunt instruments, because of extensive dissection in the pars plana area. Poorly formed SICS wounds with blunt instruments. All of that can also cause detachment. You can have ciliocoroidal detachment, which can be secondary to REG-RD, secondary to uveitis. It can also be iatrogenic if you were to do certain procedures in which there is wound leaks. You can have ciliary body shutdown. Ciliary body shutdown typically will happen acutely. So if you see a patient of a HLA-B27 anterior uveitis, acutely red eye, which is tender, which is also painful, pressures will typically be low because there's just a shock to the system. The ciliary body goes into shock. You can have drug toxicity. Certain systemic drugs can cause the ciliary body to go into a state of shock, and it'll transiently reduce or minimize aqueous production. You can have insect stings, typically bee stings. You can have venomous stings like scorpion bites or insect bites peripherally, which can also cause the same. Or it can happen after prolonged extensive. You do a 2-3 hour surgery with a lot of dissection. You can have that happening, for a few days after that, because the ciliary body will take time to recover. It can be secondary to retinal detachment. REG-RDs typically are known to cause increased uveoscleral outflow, so they can independently of choroidal detachment cause low pressures, but with concomitant choroidal detachment, the pressures can be precipitously low. And you can have systemic conditions, which are very rare that we tend to see, but they can happen and you will tend to see them more in institutes because the patient will have systemic comorbidity. So metabolic acidosis, typically it happens in patients, in diabetics who are uncontrolled, have diabetic ketoacidosis, they will have softer eyes. If the patient is hypovolemia, there is shock, of course, at that point in time. The hypotony will be a less of a concern. Saving the life is more important. But myotonic dystrophy is something that I'd like to bring to your notice. If you were to look at some of these pediatric patients, it can just present with unexplained bilateral ocular hypotony, and almost impossible to treat. You can also have certain medications. So, a patient who had high pressures or was thought to have high pressures and was put on aquasuppressants, anti-glaucoma drugs, typically oral Diamox and the ilk, and they can cause pressures to be low. Or you can have erroneous, either concentrations or drugs which have gotten into the eye. So you have intraocular MMC, which was not meant to be there, it was meant for surface application. You can have a wrong dose of melphalan that you were doing for retinoblastoma that can cause, you can have ETO or formalin through your, let's say you were doing a cataract surgery, you had a complicated cataract surgery, you wanted to go in with a cutter, and those cutters typically tend to either be ETO'd or, depending on certain other instruments, having formalin. And if the ETO is not given enough aeration time to dry off, if you use that, it can cause hypotony along with other changes also. As far as the late causes are concerned, you have overfiltration or micro leaks, which again, our glaucoma colleagues tend to see a lot of this when they use, MMC. Those thin cystic blebs will cause late onset hypotony. Can also happen after TGM surgery, or because of any other reason. If the patient's had extensive scleral thinning and there's uveal show, you can have very mild kind of leaks, which will happen much later. It can also happen after an infected or exposed scleral buckle, which has been there for a long time. You actually get it out, and the pressures are low after that because there's a huge area which is almost bare, a kind of bare choroid, and that's causing a micro leak, and those are also very difficult to manage. Sacral dialysis clefts, as we talked about, early hypotony can be there as a cause of late hypotony also. Patients who've had large retinectomies or large chorioretinectomies have a large areas of bare sclera, typically have low pressure, they have a lot of increased posterior uveoscleral outflow, they also have decreased production and also very difficult to manage. If the patients can have ciliary body ischemia, which can typically happen when the blood supply to the ciliary body is not there. Ciliary body, we must understand, is a part of uvea, so extremely vascular and also hence extremely sensitive to low blood pressure. So ocular ischemic syndrome, VZV related on, typically one of the causes of hypotony is because the ciliary body gets damaged. We treat the retina, we try and treat the vessels, but there is almost nothing that we can do for that. If you have large vessel vasculitis, typically if there's the arch of aorta is involved in Takayasu's or in giant cell arteritis, it can cause a hypoperfusion, and similar thing. The patients have cyclodestructive procedures in the past, or you've had anterior segment ischemia because of multiple squint surgeries. All of those can also cause ciliary body ischemia and hypotony. You can have atrophy, which can happen as a consequence of all of these factors of ischemia. It can happen secondary to chronic uveitis. It can also be because of avulsion or ciliary body trauma, which has not been fixed in time. And then you can have a cyclic membrane formation as late causes. And I'm not going to be, talking too much on that because we have a talk on this later. But chronic uveitis, endophthalmitis, multiple VR surgeries can actually cause this. And I'm going to quickly round up with 2 slides. So typically, if you have acute hypotony, you want to try and rule out a wound leak. You want to stop all anti-glaucoma medications, do a good drug history. You can consider, start topical cycloplegics and topical and oblique or oral steroids, depending on whether there is hypotonic maculopathy or corneal changes or not. If that's not working, you could consider local depo-steroid injection. You must rule out a RD, reg RD and choroidal detachment on ultrasound or by clinical examination if the media permits. If there is a reg RD, one should strongly consider doing vitreous surgery at the earliest. And after doing all of that, depending on where you're at, you should give 6 to 8 weeks for whatever you're doing to try to act. It will not go away in a jiffy. And a UBM is not indicated in acute post-op hypotony. It's for chronic cases after you've ruled out wound leak and that. And the UBM can show you something like that, which is supraciliary fluid. I'm just going to end with this, that this is what you want to see on the UBM. This is healthy ciliary processes, and they have the finger-like projection. If you see that, then it's great. Almost always, these eyes will not have hypotony. You do not want to see that because here you see that the entire ciliary body is thickened. It is much thicker than the, but the good thing with this is that this is not chronic, and this can actually go away. If you treat it, it's actually something which has happened in the so the hypotony has not been long-standing. But if you see that the ciliary body, there is no finger-like projections, so it's actually bald, and there is a linear membrane in front of it. So not only is the ciliary body atrophic, there is cyclic membrane also, which is a cause for late hypotony. With that, I'm just going to finish. We have our Retina Fellows Retreat, a program which is absolutely focused towards the fellows who are being trained in retina and early career retina specialists, happening on the 3rd or 5th of April, and everybody is welcome and encouraged to attend. Thank you.
Thank you so much, Mohit. I think you've beautifully highlighted all the causes of hypotony, early as well as the late onset. I think we can take up questions after Dr. Unnikrishnan's talk on management of post-surgical hypotony. So Dr. Unni is Director of Chaitanya Eye Hospital in Trivandrum, and he would be highlighting the management of post-surgical hypotony.
Thank you, Dr. Manisha, for the kind invitation, and Dr. Mohit for most of the talk. So I'm planning to say the same things in a bit more colorful way, basically. So as Dr. Mohit has mentioned, either it's increased outflow or decreased production. So the changes that happen to the optic nerve include swelling because of the lack of pressure, the lack of perfusion happening, and that in turn with scleral infolding produces the folds that we see in the condition. So I'm just going to skip this slide. And this is a very typical appearance of how this is a post-RD surgical hypotony. The retina is attached, but you see the disc, there's a bit of gliosis on the disc, there are a lot of folds, the vessels are dilated, and you see folds running across the macula. So it's a very typical picture of how hypotony maculopathy would look like. So the workup, as Dr. Mohit mentioned, includes an OCT, an ultraband biomicroscopy, a UBM, a regular B-scan ultrasonography, and sometimes fluorescent, though not very diagnostic, may show features of accessory disease. So how surgery produces hypertony? Let's look at the main causes. One, an excessive filtration, the formation of a cyclodialysis cleft, a bleb leak, and if it's a glaucoma surgery, a GDD device without adequate production and excessive filtration. So this slide shows how it stops. Repair the bleb, repair the cyclodialysis area, a scleral flap resuturing or tube ligation, or now there's something called tube stenting also, where you can put a temporary tube or even vicryl inside the HDD device to reduce the flow. So a simple algorithm would be, first confirm the hypertony, see if you can identify the leak, or if there is no specific leak, it could be an overfiltration, or it could be due to an excessive through the HDD device. So the options are to start with conservative therapy and repair the Siedel's leak. If it's an overfiltration, there could be compression sutures can be used, or revision can be done. And if it's an HDD device, there is a ligation where you can do a temporary ligation or introduce a stenting device inside if required. So again, so I just want to show you the temporal, the management. This is a new point we're introducing. Letting hypertony persist is what produces permanent visual damage. So this is one condition in which identification and management. So identify why it is in the urgent phase, 0 to 7 days. If it's a leakage, a Siedel's positive, and lack of conjunctival coverage over the bleb, you need to take care of it urgently. So here you have your conservative methods managing, but you cannot wait to see if the conservative managements kick into action. You have only limited time. And another temporizing measure could be to fill the AC with an OVD so that it reduces the aqueous flow till the leak either heals by itself or the flow through the leak comes down, or even early cyclodialysis clefts, they close by themselves. Early management would be when these emergency managements fail, and they could include a repair like a conjunctival compression suture, more long-standing OVDs, or even collapsing the bleb so that the filtration is reduced. While if it is refractory for more than 4 weeks, you need to do more definitive methods like a total redo of the surgery, the bleb repairment, advancement, scleral flap, a more invasive cyclodialysis, cleft repair, or definitive VR surgery if the retina is the cause, or persistent changes are the cause of the hypertony. Some of the newer advances are an agents called HealerFlow, which is an AC OVD agent would last for longer than we know autologous blood or placement-rich plasma. There are tube modifications called the Ahmed ClearPath, which has smaller plates. It has a more regulated drainage than the regular GDD devices. MIGS is a strategy that prevents, that can be done in a phased manner to prevent sustained hypertony. You have avoiding surgery itself by sustained release implants, with bimetoprost being a new one, and collagen cross-linking of the blebs is something to increase the strength of the bleb nowadays and reduce filtration. So we've gone through the conservative, we'll just go through the conservative managers that use steroids just to increase the pressure, systemic steroids also. Atropine to deepen the AC, rotate the ciliary body, and to some extent to close small cyclodialysis clefts. Other temporizing agents would include intracameral OVD and aqueous AC gas injection for the very point of reducing the flow for just that short period of time for temporary leaks to close by themselves. More definitive of the same would be the use of a large BCL. But one important thing is that whatever temporizing measure, the name is temporizing, it requires extremely close follow-up, extremely close monitoring to see two things: does the leak stop, does the AC reform? So there are other mechanisms that we mentioned about how to take care of the leak, the cyclodialysis, the GDD device, and also surgical management on the posterior VR segment for choroidal detachment, removal of membranes from the surface of the ciliary body in a late stage. So I'm just skipping all these because they're going to be dealt in the subsequent talks. So this is just a video to show how to do a proper resuturing of all the meticulous resuturing of all the edges. Two sutures put on the side of the bleb and all around the bleb in a bursting manner to reduce leakage from an overfiltering bleb. You can see that it is going in a very meticulous bursting suture around the bleb to try to encapsulate it faster. So this is autologous blood being injected, and again limiting the site is injected on both the sides of the bleb so that a scarring happens on the side. The same thing happens, not injected directly into the bleb. So this would be okay, and this is something in which we've put an encircling band around a post-vitrectomy eye which had excessive leakage without a particular cause, and this is the outward result. You can see the top left-hand corner had disc edema. It's an oil-filled eye, so that takes away all of the causes for hypotony. You cannot remove the oil. So with the oil present, we put a buckle all around it, and that kind of stopped the flow around it. And you can see the change in the vessel diameter, the change in the disc edema, and the reduction of the folds later. So there are some basic risk factors studied in postoperative hypertony. That is, a male gender, a younger patient having myopia, and the use of metabolites. So when these are the risk factors, especially the metabolite use, you have to expect postoperative hypertony. Early recognition is critical. That is, daily CDLs, daily IOP monitoring, looking at the OCT, the AC depth, and looking at the bleb on a daily basis to see whether the height of the bleb, the width of the bleb, or the filtration is increasing or decreasing. The strategies would be to identify first, have an algorithmic approach, conservative management, less traumatic management first, watch for anatomic visualization, normalization fast, use a multi-dip. So you need a glaucoma surgeon, probably a corneal surgeon, and a VR surgeon and uveitic specialist all on board for this. So you have a sequence. This is the algorithm, or a sequential method. Using a BCL, cycloplegics, blood, compression sutures, temporizing with OVD, surgical blood revision, and cyclopexy and VR surgery in order. So these are the success rates of the various interventions. You can see intervening. So basically, I would say, while management, there is a low risk of management, that is conservative management, and it goes all the way up to higher risk complication management with bleb revisions, scleral flap resuturing, cyclodialysis, and tube modifications. So meticulous surgery prevents hypertony, judicious use of mitomycin, releasable sutures, meticulous wound construction and review immediately intraoperatively, using valve incisions, leaving OVD in a case where you anticipate risk factors, and choosing appropriate valve devices in critical patients. So in hypertony, the key principle is timing is everything, recognition, having an algorithmic stepwise approach. Thank you.
Thank you, Dr. Uni. I think you've beautifully elucidated all the post-surgical causes of hypotony and how to go about managing them. Are there any, first of all, I just want to know, is the audience able to hear the speakers? Because we have a lot of voice coming from the next hall. I hope they're audible to everybody. So are there any questions to Dr. Mohit? Yeah, please.
Who were on like higher teens, and they were on medication, suddenly developed CDs a year after trabeculectomy, and the bleb is flat, and actually I was treating them with medication because bleb was not over filtering or anything. There were some signs of inflammation though intraocular, which we did steroids, and now they have CDs, and I don't know why suddenly it is happening in 2-3 patients a year after trabeculectomy. And patients were actually on anti-glaucoma medication post-trabeculectomy because we wanted to reduce the pressure. And I think they were fairly well managed. The surgery was uneventful and everything went well. And suddenly a year after they developed CDs and a shallow AC. So we are doing topical steroids, but even if we drain, it is multiloculated. So how many places can we drain really? So we tried PST, we tried difluprednate, everything. So what's the next thing, and what probably is the reason, if you could help me?
Your last sentence was the most important sentence. That is, what probably is the reason. So we can treat with all these methods, but the most important thing at this point would in my view would be a UBM. That is, if you have something happening so late, I would think it would be really important to know what is happening at the ciliary body area. Whether you said there were some signs of inflammation, so a chronic inflammation would be the cause. Could be a cause of membranes on top, and that could be a cause of hypotony. The second thing is, even looking at the structure of the bleb, now we have anterior segment OCT and we can pass that through the bleb structure. And that could also probably, I'm not sure what has been, whether it's long-term chronic sweating blebs have been described. They cannot be identified so easily, but some sort of slow hypotony happening. And there have been reports about systemic conditions worsening, that is chronic hypotension or sleep apnea syndrome worsening aqueous production in the long run also has been mentioned. So having a tottering eye, which is just borderline pressure, and something systemically happening can also tip the scales. So as I said, there are multiple things happening. The most important would be to look exactly at the place that is a bleb, and all around 360 degrees, that's the ciliary body.
Thank you.
Yeah, please go ahead.
Emergency to intervene, and the pressures are 5 to 6 or 4 to 6 after glaucoma surgery. How long can we wait?
So the patient has undergone a TRAB,
Yeah.
and maintaining a pressure of 5/6.
Yeah.
And you are wondering that for how long can we maintain the eye on a pressure?
It's good
So I
enough.
think if you're not having any manifestations of ocular hypotony, I think you can just hold on and observe the patient. I think there's no hurry, unless or until you are having any side effect of the 5 or 6 pressure that the eye is maintaining. Are you seeing any effect of the low pressure on the eye?
Yeah, there's a bit of hypertonous retinopathy has started. So,
And there's no overfiltration of the bleb that you're having?
I mean, the AC is well formed, and the ACs of both the eyes are similar, AC depths. So, how long can we wait for that?
I think you can wait. What's the hurry? Because the AC is well formed. 5/6 pressure is not too bad. And if the eye is like you're not having any choroidal folds, you're not having any optic neuropathy secondary to hypotony, I think you can just observe the patient, put the patient on steroids and observe. Sometimes we also put these patients on diflucor, which helps in raising the IOP.
I've done in one patient, nothing
It didn't work.
Yeah, nothing happened.
Uni, any suggestion?
My point would be that if everything you said was like that, and then you said that there's hypertony, macular changes, that is an indication for intervention. Okay, you cannot have persistent disc edema or maculopathy changes.
And suppose there is no hypertensive retinopathy?
There's no
hypotonous retinopathy has not started and the pressures are 4 to 5,
Then
we
like
can
age,
wait.
it's just a number.
Okay.
Okay?
And
Then
one more question, sir.
if there are no manifestations, like Madam said, if there's no manifestations of hypotony, then it's just a number. Okay? You can wait till it increases, but you should be equally vigilant to look whether the manifestations are appearing. And if you want to get to the end of the problem, you'll have to go through the algorithm, investigation algorithm. Try to find out why it is leaking excess. And if you can't or cannot answer that and you still don't have manifestations, then it's okay. You can just keep watching it.
And
As a
one-
VR surgeon, we are used to 4 and 5 pressure. So we're not that really worried unless there are manifestations.
in these cases, the NCT would come more than the applanation.
Sorry?
The NCT.
The NCT pressure is usually
Yeah.
more than the applanation pressure. To rely on which one?
Whichever you rely on only that one.
I mean, normally I rely on applanation tonometry.
No,
but
you
in
should be relying on,
hypotony,
see, if the
NCT
cornea is okay, and you can rely on the applanation, but the main point is not to change over between two recording devices. Okay. If you're used to using applanation, you have to continue using that, and to my knowledge, I think that would be a better way of doing it.
And also sometimes I've seen that when your patient undergoes a workup, the pressures recorded are pretty low. But when you digitally see the eye and you see the eye in totality, it doesn't appear to be having that kind of a low pressure. So I feel we should not be overpushed by just what the instrument has recorded, because there are several factors why the pressure could be recorded low by the instrument, such as the corneal thickness and other things. So as long as there's no manifestation of ocular hypotony and you feel that the eye is pretty good and stable, I think you can just hold on.
Thank you.
Yeah, Mohit, please go ahead.
I want to make one more point. Typically pertaining to glaucoma patients, as one more indication to try and think of intervening, even in the absence of hypotonic maculopathy, if it's 0.8 cup and above, and if you've been following the patient on 24-2 field initially, and then you had to shift to 10-2, right? Because you have those patients in which 24-2 is actually gone, and you're only, so that means only a sliver of those fibers are left. If you have low pressures in them for a longer time, you can have a snuff out phenomenon. It will not just happen after glaucoma surgery where the pressure is brought down in one go. So if the patient is 0.8 cup or above, and the only thing that you were doing is following the patient on 10-2 because 24-2 was all black, then then even in the absence of hypotonic maculopathy, you could actually cause the patient to become hand motions suddenly. So I would say you would rather err on this, because then it is irreversible. फिर कुछ नहीं कर सकते. So that is also one indication, just particularly for glaucoma.
I now invite Dr. Vishali to speak on atrophic hypotony secondary to chronic uveitis.
Thank you, Manisha, taking up such a challenging topic at 4:30 p.m. in AIOS. Hats off to you. Okay. So, a topic which Manisha has given me is atrophic hypotony due to chronic uveitis. Perfect. So Mohit has already told this. I will not go into it. Hypotony, when we talk of it, it can have different types. It could be functional, like we were discussing just now, where IOP is low, but there is no structural damage. It could be structural, which means now the structures have started getting damaged, and that is the time when you start to intervene at this point of time. Because if you don't intervene at the time when there is a structural hypotony, you could end up in atrophy, which is the late stage of structural hypotony, which means your ciliary body is atrophied, reduced production, and progressive ocular structural damage. What causes hypotony? Most of the time, decreased aqueous production, increased uveoscleral flow, cyclitic membrane, which causes the traction on the ciliary body, and finally, the total damage and atrophy of the ciliary body. There are several risk factors which, in context of uveitis, I'm talking about. It could be long-standing uncontrolled uveitis, multiple recurrences because we are in a great hurry to reduce steroids for the fear of glaucoma. So if these patients are not put on immunosuppression, there could be recurrent episodes, delay in the therapy, development of cyclitic membrane, posterior segment, too much involvement, multiple ocular surgeries, and children. The signs you all, Mohit has told you, I'm not going to get into signs. So what are the management principles in uveitis? The first and the foremost is to control the inflammation. We would try somehow to restore the aqueous production and prevent the structural damage. Now, what management are you going to do will depend at what stage you are seeing the patient. Now, I'll give you an example of this patient. This is a patient who has glaucoma as well as who also has intraocular inflammation. And if you look at his, I mean, it's an optos, but he does have a fairly advanced cup. Now, I think patients like this, even before glaucoma surgery, you have to make sure the eye is absolutely quiet. This eye is not really totally quiet, and this is what typically happens. On post-op day 1, you might end up with a pressure low, vision is of course less, and there is effusion. If it is purely an effusion and it is a phenomena like this, you know this is temporary, you got to increase your steroids. And I prefer using Durazole in these patients because that really causes the topical Durazole really causes the pressure to go up. Oral corticosteroids in good dose you will need. And this is how you will get rid of the hypotony which occurs under these temporary circumstances. The second is the advanced case, which is not atrophic as yet, but which has started having structural change. I'm showing you an example of this patient of uveitis, which was diagnosed as panuveitis, was being managed, and suddenly he was lost to follow-up and came with very severe form of uveitis. While he was getting investigated, he again did not show up and came back within 6 weeks with very severe hypotony. I could not get the anterior segment picture, but you could actually see it behind the iris, the choroids, and everything. Now, this is the point where you know the structural damage is occurring because you can look at the fovea, you can look at the folds, and it's not only the choroidal detachment. You will of course try a medical management, but not for very long, because for this patient we tried and it was not working. And that is the time you know that the longer you keep on waiting for it to go back, the more chances that you will end up with the atrophic changes. So you can see there is a fold which you can try to gently, soften it, erase it, to flatten it as much. It's a uveitic eye. So there is not, the membranes are not just going to come out in a single go. So you will have to take care to remove some of the vitreous plaques. In this eye, finally PFCL was injected, dissection done. If there is a cyclitic membrane, which this patient did not have, you will have to peel the cyclitic membrane, and instead of pulling the cyclitic membrane, just give few relaxing incisions. That's what works most of the time, because trying to pull the cyclitic membrane itself can be quite traumatic and result in the ciliary body cyclodialysis later on. So this patient, we had an oil fill, and you can see that this is taken care of, hypotony. His pressure was 8, and actually a few days ago it went up to 20. So you have to intervene at the right time. The last stage is, we are not seeing it anymore. We used to see them in past. These are the children with JIA who are not treated properly. They end up in the late stage like this. You have BSK, you have sometimes short eyes, and you have traction on the ciliary body. So these are the children where you have to do a vitrectomy, do cyclitic membrane. I would call it still relaxation of the cyclitic membrane, desegmentation, and finally fill up with the oil. However, we have to remember, when we talk in context of uveitis, if hypotony has happened, it is your fault, and there are no two words about it. If you are the treating physician and hypotony has happened, unlike glaucoma surgery and others, you better blame yourself for this. And how can you prevent hypotony? It is all the children and very aggressive form of uveitis. You do step down approach instead of step up. Step down is, you see today a child with JIA and severe inflammation, go with biologics as first line of therapy, and then try to maintain them on DMARDs rather than doing low dose steroids, increasing steroids, methotrexate. And when hypotony steps up, at that time you start thinking of moving on to biologics. So that is the step down approach which you can this. So in essential, to conclude, as far as the uveitis goes, treat aggressively and judiciously, and hypotony should not occur, because hypotony in uveitis is not incidental. It does not happen without a reason. Thank you, Manisha, once again.
Thank you so much, ma'am. Are there any questions from the audience? Yeah, Dr. Sangeet.
For hypotony, Sangeet, actually, I'm not a big fan of putting oil for hypotony. We did publish about 15 years ago that eyes with these hypotony, you put oil. But if you ever reach that stage, it's mostly silicone oil exchange. We will never be able to take it off the house. So it is 5,000. When it starts getting emulsified, just exchange it.
Like you said, one case when it was 5 and then it became 20. So at that time, would you consider removing oil in those cases?
That case, I still will not consider removing it. I prefer 20, because if I remove oil and he again goes back to 5, I would tolerate up to 30 with 1 or 2 anti-glaucoma rather than removing the oil for, because these eyes are sick eyes, so they have a tendency to go into hypotony again.
Thank you.
Thank you.
Ma'am, I have a question for you. Yeah, please go ahead. Please. Can you please take the mic?
The patients of uveitis have episodes of hypotony and hypertension. So how do you counsel the patient when to visit you? Because we may miss these episodes.
I'm not aware of patients of uveitis having episodes of hypotony,
I mean, they come with a raised pressure, then you give them anti-glaucoma, then the pressure goes down very much.
Because hypotony in uveitis typically occurs when uveitis is active, and that is because of the temporary ciliary body shutdown due to inflammation. And when we start using topical steroids, that hypotony becomes reversible. That's not really the case. On the other hand, an active uveitis patient comes with high IOP. The chances 90% are it's a viral anterior uveitis, which needs to be managed like this. So I don't think these patients have alternating episodes of hypo and hyper. And I'm personally a uveitis expert, and pressure of 25, 30 doesn't really bother me as long as the patient is under control. Because majority of them do not have advanced glaucoma to begin with, unlike the patients with glaucoma. So they have healthy discs, so even if pressure goes up a little bit, it's okay. I mean, most of the time what I see, the comprehensive ophthalmologists are so scared of steroid-induced glaucoma that they do not give the appropriate dose of topical steroids. They wean it off too quickly, which results in another episode, and in the long run, that is much more harmful than just managing glaucoma with 1 or 2 drops. Yes, Manisha.
Ma'am, there's one more question
Yeah.
for you.
Just finding the answers for the same case again. Like my patients developed mild signs of inflammation a year after trabeculectomy and went into CDs and hypotony. So I was wondering, is there any role of mitomycin causing such late inflammation, some kind of a ciliary body toxicity? But I did not, my flaps were proper and surgery was perfect. But I'm just still finding answers why these 2-3 patients suddenly went into a hypotony with mild signs of inflammation a year after an eventful surgery.
Yes.
So
MMC has been typically reported to cause permanent damage to ciliary body, including the delayed damage, and there are reports of enucleation of the rabbit eyes even 1 year after showing the changes. So again, I'm not a glaucoma person, but you have to be very careful, and I think that is why people moved on to releasable sutures rather than using mitomycin, because mitomycin has this inherent effect. So if it is happening in 3 cases which are out of expectation are your usual outcomes, I would also look at the change in the brand of MMC. I don't want to sound a snob, but many of the generic and make in India, they do not really, sometimes the concentrations and all could be a little bit tricky. So you will have to pay attention to it. I would suggest you doing without MMC a couple of your cases, and if it does not happen without MMC, then you know it was not you, it was MMC.
this Durazole you said, is it available commercially?
Yeah, it's available for us.
Thank you.
Ma'am, I have a question for you. When we are dealing with these chronic uveitis patients presenting with hypotony, it's always a dilemma. UBM is showing that there are extensive ciliary membranes. Now, dissection of those membranes would require a sacrifice of the IOL and doing an extensive dissection. But you're still not sure that despite having removed those ciliary membranes, will the functioning take up, because then atrophy could have set in. So how do you go about deciding whether just to go ahead and put in oil, not touch the IOL, or you would opt for a dissection of those ciliary membranes?
You know, Manisha, these are the cases where even removing the IOL is in itself, many a times you may have to just
Snip
cut
it off,
the IOL
yes.
and leave the rest of it behind.
Right.
So it will again depend what is the status of the opposite eye. But in uveitis, the less surgical intervention you do, the best it is. The more aggressive you are with the medical management, the better it is.
Right.
So one, I do not touch those patients straight away. I still give them 3 months, 6 months of aggressive biologic therapy before I take them to OR. I tell parents almost so many times that, it's like a resuscitation, we don't know and all that. I would try to be minimalistic. I would dilate the pupil, go into the anterior chamber, break any iridolenticular adhesions which would be there.
Okay.
Even making some relaxing incisions in the iris so that it doesn't adhere again. Depending on how much of PCO, ACO it has removed, I will not really try to remove an IOL in an eye which is extremely hypotenuse. And similarly, when we go to the cyclitic membrane, I will not pull it. I used to pull it, but I will now just put the relaxing, because nothing is going to make much difference, and fill it with silicone oil, which gives another 3, 4, 5 years. But again, you continue with your biologics. That is the trick, which we were not doing early. So now, even once you have put in the oil, you continue with the therapy so that something keeps happening, whatever vision is maintained.
Thank you so much,
Thank you.
ma'am. We'll move on to the next talk. I'll take my talk at the end of the session. I'll now request Dr. Sangeet. Dr. Sangeet is a senior VR consultant from Thindai Hospital, Jalandhar, and he is known for his innovative surgical techniques. He'll be speaking to us on how to go about managing choroidal detachments, which again is a very important cause of chronic hypotony.
So good evening, everyone. So I'll be speaking mainly on managing the choroidal detachments. And choroidal detachment is the eye pressures against story when the space that should not exist suddenly starts speaking. It's a potential space and not a true space. You can classify choroidal detachment into serous choroidal detachment. Low IOP promotes transudation of fluid out from choroidal vasculature, could be post-surgical, post-traumatic, or secondary to inflammation. It could be a hemorrhagic choroidal detachment due to rupture of the choroidal vessels, it could be spontaneous, it could be post-surgical, again post-traumatic, or it could be uveal effusion syndrome, which is idiopathic. So these are the various differential diagnoses. The choroidal detachments may be caused by scleropathies, they may be caused by inflammatory or hydrodynamic or neoplastic causes. The investigations that need to be carried out is a B-scan ultrasound, which we need to differentiate between a serous choroidal detachment or a hemorrhagic choroidal detachment. So in a serous choroidal detachment, you'll see a smooth dome-shaped echos with a free optic nerve. The echos will not be connected with the optic nerve. There will be no after movements and low internal reflectivity. Whereas in the hemorrhagic choroidal detachments, you see a very high internal reflectivity. The management of choroidal detachment, a simple mnemonic that could be you can learn is the choroid. C is first to check IOP to differentiate whether it's serous or hemorrhagic. Then hypotony or hypertension, treat that first. If there is hypotony, as in previous talks we have talked, you treat the hypotony. If the pressures are high, you treat them. Then observe small non-kissing serous choroidal detachment. Sometimes they do settle down on their own. You reduce the inflammation by giving steroids and cycloplegics. Then you operate only as a last resort when they are kissing, non-resolving or vision threatening. You can image with B-scan to guide timing and site of drainage, and you would delay the drainage in hemorrhagic choroidal detachment until you have a liquefaction. You delay it by 2 to 3 weeks if the eye is stable, and then you take up the patients. So this is one patient just managed by choroidal conservative management by giving steroids. You see there was massive choroidals. This is again a post-trabeculectomy patient. Just by giving steroids and trying to raise the pressure, the choroidal settled on there with the management. Now going to some videos on how to do surgery in these choroidal detachment eyes. This is my first video. The first difficulty that you encounter is placing your while doing vitrectomy, placing your cannulas into a proper space. So there's a small test that you can see here. What I do is an endo-illuminator test. Just put your light pipe into these cannulas, midway into these cannulas, and if you get this red reflex, it means that your cannula is not in the right place. So instead of going down, looking through the outside and seeing whether their cannula is there or not, you can just do this simple test. And now this cannula, you see I'm putting this light and you see this a white reflex, so this cannula is in the proper space. So this gives you an indication that your cannula was not in the right space, and then you can use the other cannulas to start your infusion, and then you can switch the infusion back when you have already managed the cannula which is not there. So I've started the infusion from the sclerotomy where it was inside, and now I am exposing the cannula which is not in the right place. So once I am removing the anterior vitreous here, and you see the cannula is in the suprachoroidal space. Using a needle, I cut the choroid which was overlying this cannula, and once this is inside, then you can switch back the infusion to the cannula. This was the infusion cannula, so infusion has to go here for a proper vitrectomy to be carried out later. So now you see that it's giving a white reflex, so I switch the cannula back. So this is another patient of choroidal detachment. I prefer to do a vitrectomy first and then drain the choroidals. Some surgeons, they drain the choroidals first and then they do carry on the vitrectomy. In this patient, I did my vitrectomy. I find that choroidals, like the self-depressants, they cause depression, and then I can see how much vitreous I have to remove. And once I completed this interior vitrectomy, I just took a 26 gauge needle and just drained the choroidal with this 26 gauge needle. This was a serous detachment, so it could be easily drained using a needle. So then carry out the vitrectomy later on. So this is a video given to me by Dr. Manisha Agarwal. She uses a special technique that she uses this cannula which is non-valved, and this she enters the suprachoroidal space, and then she manipulates this cannula to drain the fluid out from the suprachoroidal space. So this is another method of draining the suprachoroidal space. But beware, you have to put an infusion cannula before you attempt drainage of the suprachoroidal detachment. So this is another video. This is another way of doing a choroidal detachment. I use this 26 gauge IV catheter to drain this choroidal detachments. So here how it works is like this was a patient with a bullous retinal detachment, just to show how this works, this technique works. So I with the bevel away from the globe, I enter the desired space, whether it's a subretinal space or a suprachoroidal space. I just then go in and see whether the cannula is in the right place. Then I withdraw the metallic sillet and keep on pushing the plastic tubing inside. So this gives me a less traumatic way of draining the subretinal or the suprachoroidal fluid. So this was draining the subretinal fluid, and you can even connect it to your extrusion pump, and you can control the speed of the drainage also. So you see, you can just make it fast when you have to get to create space, or you can slow it down when the retina almost settles or the choroid almost settles, to prevent any iatrogenic injury. So this was a patient of a post-scleral buckling, recurrent RD and choroidal detachment, and the choroidals were reaching up to the posterior pole, and there was no way to reach the posterior choroid because there was a buckle in, and you could not have drained it. So this technique helped me here also. You see the cannula, the IV catheter in the suprachoroidal space, and then you can use this technique to drain these posterior choroidals also. And you can even, this cannula can even reach up to the macula if you have to drain the choroidals which are in the macular space. Again, this was another case. As I told you, if you are not able to put your cannula into the vitreous cavity, you can use an aqueous maintainer, but you have to fix an infusion before you attempt the choroidal drainage. That is essential. Otherwise, it may cause hyphema or intraocular bleeding because due to the sudden hypotony which is created. So this was this patient with the kissing choroidals, which was drained, the video I showed, and this is 3 weeks later. The choroidals have settled and the patient's vision has improved. So I'll skip this. This is another video which was given to me by Dr. Manisha. She uses another technique of intraocular drainage. The endo drainage, she creates a choroidotomy, and from here she drains the choroidals and then put in silicone oil in these eyes. So I think this is my last video. I end up here. Thank you.
Thank you so much, Dr. Sangeet. There were so many innovative ideas of draining the choroidals. Any questions from the audience for Dr. Sangeet? I think we have a lot of glaucoma colleagues sitting here, and yeah.
With the IV catheter, you can actually go to multiple sites because you are going transconjunctival. So it doesn't matter 1, 2, or 3 multiple sites. If you see the choroidals are multiple places, you can drain multiple sites also.
Dr. Sangeet, I have one question. After trap surgery, sometimes because of the sudden hypotony, you have massive choroidals developing. Now, how do you really go about if a case like this comes to you? For how long would you observe, or would you drain those choroidals?
As I said, like if we try to maintain, first we check whether we try to control the hypotony, seeing what is the cause of these choroidals or the hypotony, whether it's a bleb leak or whether the aqueous production has decreased suddenly because of some kind of ciliary shock, and then treat that first. If the choroidals are not resolving, surgery is the last resort.
And would you be putting any tamponade in these patients, like oil or anything? Because that will cause a failure of the trap then.
Yeah, you can use a short-acting air or gas in these cases because sometimes you need these tamponade just to, if the cause of the choroidal detachment is not a bleb leak, not an external cause, rather than something which is related to the ciliary body or the choroid, then you need to give some kind of tamponade for that ciliary body to take up the action again. So generally, I give a short-term tamponade and not a long-term gas or silicone oil in these eyes.
Nice videos, Sangeet. Comments that I had to make. Okay. So sometimes what happens is when you're doing a conservative follow-up of these patients that the choroidal decrease, there's a rare chance that you may develop retinoretinal adhesions forming.
Yeah.
So once sometimes even when the choroidals collapse, you have to take up for surgery to release those retinoretinal adhesions, especially in inflamed eyes. Like you can have that in post-TRAB also, or post-PK. Sometimes a lot of expulsive hemorrhage has happened. Things are settling down, but then suddenly you will have retinoretinal adhesions. So in those cases, again, careful placement of the cannula, and very carefully you have to separate the two sheets of retina which have come and stuck together because of the vitreous is still present here.
Yeah,
So
I
this
think
is something again you have to
tot-
keep in
yeah.
mind that this can happen.
Yes, I totally agree. Especially in cases of suprachoroidal hemorrhage, this is a very common condition because sometimes we have to wait 2 to 3 weeks for the
Yes.
blood to liquefy. But if they are kissing choroidals, these adhesions may develop sometimes, and then it becomes difficult. So in those cases, we have to intervene early, I think.
Yeah, so you have to keep a track of that if that is happening.
Yes.
Can we have the mic, please? Can we have the mic? Yes, ma'am.
Thank you for this very interesting topic. As a glaucoma person, I just need to know how many choroidals would you need to do who don't resolve by conservative management in trabeculectomy or tube shunt eyes.
Very few, ma'am. Very rare.
So that's what my observation also is. Like, let's say if you have 50, you may need to do 2 or 3
Yes.
max.
Yeah.
So how long would you ask us to wait before we say, okay, no, surgery has to be done?
I think until and unless the choroidals are causing any visual problem, there is a progressive decrease of vision.
How long would you wait? Like, let's say 3 weeks or 1 month?
Generally 3 weeks to 4 weeks, ma'am.
And if there is persistent, if there's
If there's persistent choroidals, if they are decreasing, then I can wait further.
if they're
also.
decreasing it longer, and the moment macular edema, maculopathy starts, you would
Yes.
intervene then, or you would still wait for 4 weeks?
No, that's, I think in the previous talks we discussed that
I missed-
hypotonic
I missed
maculopathy,
that,
if it starts developing, then we have to intervene early.
Because what I find is, in my experience as a glaucoma person, normally it takes time, but they do go away. Surgery, only once I think we had to get it done.
Yeah.
Mostly it does resolve.
Yes, sir.
So
Yes, ma'am.
what are the red flags that we need to do early for glaucoma? And I'm not talking about the bulla sardi and the CD combination.
I think that's one thing, like in the previous talk we discussed, was one, like Mohit said, was the snuff phenomena. When the optic atrophy is already there and very few RNFL fibers are left, and you don't see, you see all blackout on 24-2 charts, or just see some kind of vision in 10-2, then you have to intervene early to prevent at least that vision which is there. And of course, as we talked, hypotonic maculopathy, if it settles in, then you have to do it early. Otherwise, it becomes sometimes chronic, and then.
So in that case, whenever, let's say in the X amount of cases you have to do it for TRAP patients, you would prefer, if it's kissing choroidal, normally it is kissing choroidal, which site would you prefer? Again, the infero site, because trabeculectomy is superior.
Yeah. So one thing is, like trabeculectomy, even if it is superior, if you it depends on the height of the choroidals. So where the choroidals are maximum, I'll
That's
try
true.
to
Maximum. Otherwise, if it's kissing choroidal and there's no special
yeah,
extensive height, then in
yes,
that situations.
the easiest to me will be if it is right eye, I will drain the temporal side. Again, if it is left eye, then again I think temporal will be the best.
Infratemporal is that the
yes.
normal thing?
Yeah.
Okay, thank you very much.
Actually, I think I agree with you.
What
the
site?
observation.
How many millimeters away? Because I find that most retina people will tell us that it'll become all right, and it does too. So how many millimeters away would you go for it?
I think it's about from the limbus, you can say. I will go as posterior as possible if I'm going temporally, because
So
I have
as
to go into the choroid, and sometimes I have to go even posterior up to the macula. So I'll try to go as posterior as possible.
Yeah. Thank you.
Choroidals, and usually what we do is like what we find is that even there is no conjunctival leak, the main source of the reason of hypotony is drainage happening under the scleral flap. So mostly when we suture these sclera, we can do a suturing over the conjunctiva, or very rarely we can just open up it again and then suture the scleral flap, and then these
Yeah.
choroidals
Yeah, so that's
like
what I
resolves
said. The
easily.
first thing
So
you check the IOP whether it's serious or a hemorrhagic. Then the next step is you manage. If there is hypotony, you manage the hypotony first. Find out the cause of the hypotony and then manage it. If it is hypertension, then again find whether it's hypertension, whether it's some kind of a choroidal hemorrhage or not, and then you manage that accordingly.
So usually hemorrhagic will have relatively higher IOPs.
Yes.
The serous choroidals will
Lower
have
IOP,
high,
yes.
low IOP.
Yes.
So can you suggest some situations in which the posterior approach would be better rather than suturing the scleral flap?
No, I think we should manage the hypotony first. The cause we have to find. If it is draining too much, then we have to close those drainage sites. This choroidal detachment drainage is the last option.
If you've not taken care of the main cause of the hypotony, the choroidals will again occur. So I think, as Dr. Sangeeta is mentioning, I think it's imperative that we first take care of the cause rather than taking care of the CD. Dr. Praveen?
Yeah.
One of the either the cause or the result of the hypotony, and the other way is hypotony vis-a-vis because of increased fluid coming out from the scleral flaps without choroidal. So if there are no choroidals and the hypotony cause is the excessive filtration or the leak, then treat the cause.
Right.
Treat the leak, and in what I found is in myopes, very limited experience in high myopes, over time it can go into hypotony, no choroidals, and I just find that putting this that sclera, even if it's intact, just putting a small patch graft over that sclera will resolve the hypotony. So I would again go for an anterior approach before going for the posterior. But moment you have choroidals, then if they're not resolving, then of course by handling only that it may not work. You were saying something.
Actually, I have seen my glaucoma colleagues manage the serious shallow choroidals that you sometimes have post-trabeculectomy conservatively for many months actually, because they don't even sometimes give steroids for it because they feel it will settle down, systemic steroids. So the point that Dr. Sangeeta is making, if it is hemorrhagic, usually we have to go in earlier. But for serious choroidals not causing any hypotony, I think you can wait and manage conservatively for a very long period of time without really causing a permanent damage anywhere.
With systemic steroids. You know what I also find, again, this I'm not in the retina purview, but what I find when these hypotony and early choroidals, because subclinical choroidals are pretty invariable in trabeculectomy, what I find is it's a very small tip, making the patients walk around, Normally patients, whenever they have any eye problem, they tend to just lie down and not move around. When they walk around, of course, with cycloplegics and systemic steroids, that goes without saying, when they walk around for some reason, when they come back after 10 days, invariably they are okay. So maybe it's the circulation which happens or whatever happens, or they feel comfortable, and it has worked so many times, because we are a hospital who admits patient. आप लोग तो admit करते नहीं हो. We admit patients, and पहले था कि you keep them there and you put them on conservative management, and the patient would say, only send me when I'm okay. I found that moment I send them home and ask them to walk around really diligently for half an hour every day, moment they come back 5 to 7 days after, they are fine. So it seems to work.
I think some kind of ciliary shock is there which
The
which is taking
circulation,
care.
I
Yes.
think the whole eye undergoes some type of a vascular compromise, and then it just
I remember when I was in PGI, my glaucoma colleagues, if there was a ciliary shock, they would used to give IV dextrose to the patient, and then or drink a lot of water, and sometimes that used to take care of these things.
Yeah, वो Mostly it's time.
Thank you, Dr. Sangeet. I'll request now Dr. Parveen, and she would be speaking to us on dealing with tractional hypotony. Dr. Parveen is a very senior vitreoretina consultant at Agarwal Sai Hospital, Chandigarh.
Yeah, thanks Manisha for having me here, and I think a lot of things that I have brought in my slides are covered already. So quickly, just a recap of all these things. There are many causes of tractional ocular hypotony, but I would probably talk on three very important causes. One is because of anterior PVR after retinal detachment repair. Second is ocular trauma, and third, chronic inflammation or uveitis causing extensive ciliary body membranes. So what happens? What are cyclitic membranes? These are fibrovascular proliferations which grow on the ciliary body over to vitreous base and even onto the peripheral retina. So this is important that they cover this whole area. So they spread along this, and when they cause fibrosis, they have fibroblasts. They can cause contractile, they have contractile properties, and this contraction can pull the ciliary body, causing detachment and lead on to hypotony, and then is where we have hyposecretion of aqueous. So most important first is, before you start management, is clinical evaluation. Look at the intraocular pressure, and like discussed earlier, look at the visual potential, not just go by the number. It's not the number that helps you decide whether you're going to intervene or not intervene. Equally important to know where not to intervene as well. Investigations, usually three are the most important. One is anterior segment OCT, second is ultrasound biomicroscopy, and third is B-scan. UBM is the go-to investigation to look at the ciliary body, because it can give you the information even in an opaque media, and also that it has a better penetration. B-scan is important because it could show you the length of the axial length, whether the eye is going into phthisis or becoming smaller, in which case you may want to go in earlier. So it is important. UBM, here you can see the cyclitic membrane and detachment happening. Also, if you are going to plan a cataract surgery, especially in a uveitic eye, and if you see your ciliary processes are not intact, and or there are presence of ciliary body, you may end up removing the lens in toto or intraocular lens as well. So the surgical technique is also dependent upon the UBM when you take a decision after UBM. And in VR surgery, if you are planning, it will show you where these membranes are densest. So suppose it's a case of pars planitis with chronic uveitis, so your inferior area is going to be compromised. So you need not necessarily fix your cannula in the infratemporal space. You may go elsewhere away from the area where there are less ciliary bodies. So all this decision making can be done based on UBM. This is a medical management which we have discussed earlier, that you could give steroids and cycloplegics, but ultimately once you see ciliary body causing tractional hypotony, surgery is the answer, and this could be etiology specific and tailored approach. So after agmetogenous retinal detachment, if you have anterior PVR, it causes something called the donut shaped retinal detachment, or anteriorly you be having, and posteriorly suppose the laser barrage is keeping the retina attached. Even then the anterior retina which is detached is enough to cause proliferation, formation of these membranes on the ciliary processes, which will result in a hypotenuse situation. So here the treatment involves the meticulous removal of all these peripheral membrane, relief of traction, and sometimes even relaxing retinotomy will be required. Here you can see the interior retina is detached, and the steps involved is, you obviously, a lot of VR surgeons will be used to this kind of a procedure, that you do diathermy, you cut off the retina, and most importantly cut off the interior flap, which could be again a nidus for proliferation and could cause growth of membranes onto the ciliary body, causing hypotony. So in chronic uveitis, again, once you have decided that it is the UBM which shows you the localization of the ciliary membrane or the cyclitic membrane, and this is the situation which you see in a uveitic complicated cataract, and here the UBM can give you the answer where the cyclitic membranes are there, and it helps you in deciding whether you're going to use an intraocular lens after your lensectomy or not. And just showing you an example of how bad these cataracts can be. And if you look carefully, I have made the entry of my instruments right into the limbus, and I have not even, I've totally and completely avoided the ciliary body, or even, it is not even a pars plana or a pars plicaita vitrectomy, but now with 25 gauge instruments, I actually go through the limbus and do it. So this way you can avoid doing any iatrogenic breaks which can happen, because the membranes onto the ciliary body, even a minimal traction can communicate onto the retina, causing a retinal detachment. So here you can just finish off your surgery by doing this procedure of holding the infusion in one hand and doing the surgery, and if required, infusion can also be placed into the limbus. So in cases of trauma, it can happen especially in cases of open globe injury, where there is penetrating injury and there is a ingrowth of fibrovascular membrane. You can see here that this membrane has to be then cut, and as Dr. Vishali was saying, you segment it by using scissors. You need not always pull it. This is an example of a young child who had penetrating trauma, and you can see this white membrane which is growing, and this is the area of open globe injury, and the fibrous tissue has grown through this and caused retinal detachment. Here I was not able to remove this fibrous tissue in toto, so what I did was to disconnect the retina from the fibrous tissue by doing a relaxing retinectomy. And the video is bad because the view was very bad, till I could finally open up the funnel by using LPFC bubble here. So now you are able to appreciate that I have done a 360-degree retinectomy, and this cuts off the communication that it had with the fibrovascular tissue, and now I am replacing it with silicone oil. So these can be sometimes very difficult cases to do. So preventing epiciliary membrane formation is the best thing, which is by doing good meticulous vitreous base excision during all these surgeries, and good anti-inflammatory agents to be used. This video has been given to me by Dr. Sangeet. Thanks for that. And this is endoscopic pars plana vitrectomy. So sometimes when your view is not very good because of associated corneal haze as well, you can use endoscopic technique to cut these membranes and remove them. This is the segmentation. You can see the ciliary body and how these membranes are growing over it, and this allows you to do this kind of work without scleral depression. So these are dense membranes, and sometimes the peeling itself is enough to cause traction, so best is to sometimes cut and segment them and leave it then. So this is what you see. You can decide whether it's an atrophic ciliary body. If you see on endoscopy, you can replace the use silicone oil to give a tamponade as well. So the prognosis will depend upon whether it is acute or chronic, whether it's established ciliary membranes which are there and it's an early traction, or it is late, in which case you might have to leave it also if it has been for a long time. So when not to operate, surgery may not help if there is no visual potential, long-standing hypotony with ciliary body atrophy, already phthisis is setting in, and as it is that if the patient is having a pain-free, stable eye. So to conclude, early identification is important. UBIN can play a key role, and tractional hypotony is primarily a surgical disease and has to be carefully taken care of with a long-term follow-up, and silicone oil tamponade may be necessary. Thank you.
Thank you so much, Parveen.
You can use it in some special situations, but a good surgery is finally the bottom line.
So Parveen, those patients where a good peripheral vitreous is not removed, do you think that they ultimately land up with a chronic hypotony?
Yeah, so the anterior PVR which is there, that is, in fact, a lot of us, earlier days we used to do a 360-degree laser, or we used to do a belt buckle to make sure that then we do a good vitreous base excision. Now, you must have seen that especially in cases where you have not been able to do a peripheral laser because of view is limited or something, that anterior retina which remains detached is enough to produce inflammatory factors and cause your anterior PVR, even when the posterior retina remains attached, and that could be the culprit of hypotony.
So coming to the last talk of the session, I will be dealing with cyclodialysis clefts. So as we all know, cyclodialysis cleft is defined as the separation of the ciliary body from the sclera. And this is very often secondary to either a blunt trauma or as a complication of a surgical intervention, very often after glaucoma surgery. The extent of the cleft may vary and it can cause a persistent hypotony in the patients. Now, if we review the literature, there are several techniques which have been described for small clefts, and this could vary right from doing a cryopexy, putting in an encircling band, or suturing the cleft. However, there's a paucity of the techniques which have been described for managing large clefts which are more than 180 degrees in extent. I'll just show you a video and of a young boy who was managed by me. 14-year-old boy with badminton racket injury to the right eye and vision of 624 N24 and a pressure of 2 millimeters of mercury. There was subluxated lens and hypotony maculopathy. There was 360-degree cyclodialysis cleft.
Here's how a sewing machine works. There's a threaded needle above the fabric. When it pierces the fabric, a rotating shuttle hook below catches the thread.
We present the sewing machine technique to repair a cyclodialysis cleft. Lensectomy and vitrectomy was done, followed by intraopgonioscopy to confirm the extent of the cleft. A scleral flap was made and 10-0 proline suture was threaded into a 26-gauge needle. And the needle was cut off. The needle with proline suture was passed through the cleft and a loop was taken out, which was kept in place with the help of a 30-gauge needle. This was repeated multiple times and multiple loops were taken out, which were kept in place with the help of the 30-gauge needle. The 30-gauge needle was extended to keep all the loops in place and the suture was finally pulled out. And the tenoproline suture was then passed through all the loops. The 30-gauge needle was removed and the suture was tightened. This was repeated on the other side as well. Same technique which is done 360 degrees. The follow-up at 12 weeks showed a vision of 6.9 N6 with an intraocular pressure of 18 millimeters of mercury. So till now I would have done more than 20 such cases and they're all doing very well. The only flip side of this technique is that you have to sacrifice the lens to approach the ciliary area. And I've now done secondary IOL implantation also in these patients and they're all doing well without any complication. So this was one of the studies that we did and we have now quite a few patients. Of course, this was the data between the year Jan 20 to 24 and till that time I had done about 5 cases out of which 4 were after a blunt trauma that they had a large cyclodialysis cleft and 1 was after a trab. And all these patients, they apparently have a follow-up of about a year with an average post-operative IOP of about 10 millimeters of mercury without any post-operative complication. So when we have these patients of large cyclodialysis cleft, we know that the management is tough, but they gradually start slipping into a hypotonic neuropathy and choroidal folds, maculopathy starts developing, and of course there is a gross diminution of vision. So the earlier that we manage these clefts, the better it is, and the patients, they do pretty well by using this sewing machine technique. It's just something which we need to learn. But apparently these all patients have done extremely well with the long follow-up that I have. So thank you so much. I just wanted to share this technique with you. Any questions?
Actually, just a comment that you are using 9O proline suture. So the same suture can be used to put a secondary IOL in the same sitting.
Absolutely. But it is just that, ma'am, that we don't like to do it in the same sitting.
Yeah, of course, that's an option.
Yeah.
But
because we want the eye to develop some pressure before we plunge into
and
a
that
secondary.
area where you anchor the IOL will be an additional area where the cyclodialysis can be repaired.
Absolutely. So I just thank all the speakers. We've had a very wonderful session on chronic hypotony. I would request all the speakers to come for a group photograph and we'll close the
Dr.
session.
Manisha, just one thing. I read some article in which they had used that capsular tension ring around the cleft area. They place it in the sulcus, and they said this tension ring just pushes the silly body behind and causes the closure. What is your comment on that?
I've also read that technique, but I still haven't done it in any of my patients because I'm very comfortable with this technique. But yes, probably that also is going to work.
Sometimes a simple injection of gas can also work in cleft is a small size.
But that's for the small clefts. But here, as I showed, these are very large clefts with more than 180 degrees of
So especially if they are post-traumatic, they will also be associated with traumatic mid-races, in which case you will have a flat AC the first day and IOP will be sky high.
I don't remove these sutures, they remain there. But you know what I've realized, that sometimes even when I've done a secondary IOL implantation, and if you snip off these sutures, already the addition has taken place. So whether the suture is in place or it's out, it doesn't really matter.
You can add some cryoablation to that area if you want to increase the inflammation and scarring down of the cyclodialysis cleft.
The only thing I feel sometimes that it doesn't go the other way around, ma'am, when we do a cryo.
No, but when it's a limited area, you can always do it.
Absolutely. Yeah.
In fact, earlier for smaller procedures, without doing anything, we just used to cryo it and leave it there, and that used to take care of the. And I am also belong to that era when we used to do cryo and put a SFIOL in the area of the cyclodialysis cleft, localize where it is, and definitely put an SFIOL there, because anyway you're going to take a suture, so that will repair the cyclodialysis cleft as well at the same time.
So thank you so much for attending this last session of the day. And I'll just request all the speakers to come for a group photo.